All right, engineers, in this video we're going to talk about COPD, or chronic obstructive pulmonary disorder. So let's go ahead and get started. All right, so let's go ahead and get started on COPD. So there's two conditions with COPD, chronic bronchitis and emphysema. Okay, so that's the two important ones that we're going to talk about here. Sometimes people will consider chronic asthma as a part of the COPDs, but again, we're going to keep it separate for itself, okay? So the main ones that we usually classically associate it with is chronic bronchitis. And this one is going to be classically seen with that mucus production, that productive cough. That's one of the hallmark signs of chronic bronchitis. We usually can diagnose this based off clinical diagnosis. So how much sputum they're producing, how often, how long, that kind of stuff. And the other condition that we're going to talk about is emphysema. Emphysema is usually described as being structural changes, and we'll talk about why. Okay? Now, what are the causes of COPD? So we're going to go over the pathophysiology here. We're not going to go into an insane amount of detail, but we're going to try to hit the most important stuff. So what are the main risk factors associated with COPD? Well, the one that I want you to remember that is the biggest one, the most important one, causes like 90 to 95% of the COPD cases is smoking. So let's draw a little sig here. Look at that, nice little sig, little point there at the end. Here, this guy's burning it right now at the end. And then here, we're gonna have some smoke coming out of it, all right? Again, don't smoke. I'm not promoting that. All right, smoking, it is the number one cause of COPD. We'll talk about what is this actual reaction that it causes COPD. But again, this is the most common one, don't forget that one. Other ones that are less common but still important to mention is going to be environmental exposure. So what do I mean? So certain things where you're exposed to a lot of dust, maybe silica. And another one is even just air pollutants, okay? So air pollutants from exhaust from different types of things within the atmosphere. Another big one is actually going to be a genetic condition, and this one is called alpha-1 Anti-Trypsin deficiency. We're going to put a down arrow here. So alpha-1 Anti-Trypsin deficiency. Now this one is kind of the least common, but it can happen. It's an autosomal dominant disorder. One of the things with this one is that usually you have to have like a family history of COPD, some underlying unknown reason why there's liver disease, and also they usually have to be less than about 45 to 50 years old in order for you to take into consideration alpha-1 antitrypsin deficiency. But again, the most common, smoking. Now, how does this all play into it? How does these risk factors, or these things that we believe to be the cause, lead to chronic bronchitis and emphysema? One other point I want to make sure that you realize here is that COPD is not always clear cut. It's not always the sense that you only have chronic bronchitis or you only have emphysema. One of the big things that we need to understand is these things often coexist. That is an important point to remember. Now, let's go over chronic bronchitis first. We'll go over the pathophysiology. We'll talk about some of the things that can develop from that, and then we'll go over emphysema. First things first, chronic bronchitis, I want you to think mucus buildup. Okay, so we have these mucus glands. They're actually located, if you guys remember a little bit about your anatomy, we have a mucosa lining, which is your epithelial tissue, maybe some lamina propria. And then outside of that, you have a submucosa, which is kind of a loose connective tissue, and you're going to have these submucosal glands. They're naturally producing mucus. Okay, they naturally produce mucus to humidify the airways, to trap up certain types of pathogens, and help to be able to keep the airway moist and humidified, okay? But in situations with chronic bronchitis, the problem is that the mucus production increases significantly, okay? And it's the result of usually these irritants, smoking, dust exposure. And what happens is this mucus plugging causes the narrowing of the airway. You can obviously see that because obstructive disorder is you're narrowing the airway. So one of the big things here is that we have to remember there's going to be hypertrophy and hyperplasia of these mucinous glands. And it's because of the airway is coming into contact with all these irritants, the smoke, the dust, the silica, the pollutants, and it's causing this agitation of the mucosa. And the way that our actual body deals with that is we stimulate these mucus glands to produce more mucus, to coat that area. So because of that, one of the classic things that we'll see here is hypertrophy. And hypertrophy is just an increase in the size of the mucinous glands. They're going to get bigger. The second thing is that you're going to make more of them. So that's called hyperplasia. And these are the classic signs for these mucus glands, okay? Now, because we also have other cells that are important for the mucus production, there is a couple of them scattered along the airway. We have these special cells, and they're called goblet cells. Goblet cells are also responsible for producing that mucus. And it's more of that, again, that alkaline mucus, which helps to be able to coat the airway, helps to moisten the air, humidify the air, helps to be able to filter out any pathogens, right? That is important. So because of this, these different risk factors, there's going to be hypertrophy, hyperplasia of the mucus glands, as well as for the goblet cells. So again, you're going to have mucus glands and goblet cells. Okay? So that's important. So there's going to be a lot of mucus production. The next thing that happens is, unfortunately, smoking especially. There's so much irritation in this area that it can actually cause destruction of the cilia. So there can be ciliary shortening. And they're also going to have less motility. So because of that, what's going to happen now? Because of that, you're going to have so much mucus just accumulating in the airways. And this mucus is going to be really, really hard to get out. So because of that, you're going to have what's called ciliary dysfunction. So there's going to be some ciliary dysfunction. And again, the ciliary dysfunction is because the cilia are getting shorter, they're becoming less motile, and they're not able to beat that mucus up, because that's one of the functions of the cilia. They help to beat mucus up so that we can spit it out or swallow it, right? But because there's so much mucus and the cilia aren't properly working, what's going to happen? That mucus is just going to sit there in the airways and plug up the airways and cause obstruction to the airways, narrowing of the airways. That is the problem with this one. Now, imagine, take for a second and imagine here, I plug up this airway here, right? Here's going to be a mucus plug. So here's a mucus plug here. Let's say here's a mucus plug here. What's going to happen? Think about this both ways here. Our airways are responsible for bringing oxygen into the actual alveoli, right? So O2 is supposed to be able to make it down into the alveoli. But because of this mucus plug, very little of the oxygen is going to make it down. A lot of it won't make it. It might have to divert to other areas where there's more patent airways. So one of the big things here is that there's not going to be a lot of oxygen getting in. The opposite is that we want to breathe CO2 out. So because of that, what's going to happen now? The CO2 that we're trying to breathe out is going to get stuck or trapped. So one of the big things with this that you'll notice with chronic bronchitis is that we can't get as much air in, oxygen-wise, and we can't get a lot of the air out. But more of it, more specifically getting air out. That is the big thing. So one of the big things that you're going to see in patients who have this chronic bronchitis is they have what's called air trapping. Okay? And this air trapping just is basically, again, think about it. As you're trying to exhale, your actual bronchioles get a little bit smaller when you exhale. You have elastin to kind of keep them open. But in general, they get a little bit smaller. So if you already have this mucus plug there narrowing the airway, and then you're exhaling, and that actual airway gets even smaller, are you going to be able to get that air out? No. So a lot of that air starts sitting down in these airways, and a lot of it builds up, and especially CO2. So you get very little oxygen in, and you get very little CO2 out, and this causes that classic air trapping. Now, going off of that air trapping effect, think about it again. You have low oxygen coming in because of that mucus plug. Here, we'll draw that mucus plug again. Here's this mucus plug. Okay, because of this mucociliary dysfunction, increased hyperplasia, hypertrophy of the mucinous glands, the goblet cells, and dysfunction of the cilia causes that mucus buildup, causes air trapping. On top of that, less oxygen is going to be making it into the airway because of that mucus plug. But more significantly is you're going to have more CO2 building up because, again, remember, CO2 exchanges here, right? But because of this mucus plug occluding the airway, especially during expiration, because as we expire, the airways get a little bit smaller, it's going to cause so much CO2 to build up. Now, this is two things. The CO2 is going to start building up in the blood, okay? And less oxygen is going to make it down into the airway and perfuse into the tissue. This is a VQ mismatch, right? This can lead to hypoxemia. And another one, which is really bad here, hypercapnia. And hypoxemia is the low partial pressure of oxygen, and hypercapnia is the high partial pressure of CO2. So this is one of the big common findings that we're going to see in patients with chronic bronchitis, okay? So again, hypertrophy, hyperplasia of the goblet cells, the mucus glands, because of these irritants. They make more mucus to compensate for that irritation. The mucus starts obstructing the airways. On top of that, especially due to smoking, and again, those air pollutants as well, the cilia are become shorter and they're going to become less efficient in being able to beat the mucus. So now you have an increase in mucus and you can't even get the mucus out. That builds up and causes mucus plugs. These mucus plugs lead to less air coming in, but specifically, more of the actual issue is going to be there's less air getting out, particularly CO2. Because of that, you're going to have a buildup of CO2, particularly, and this is called hypercapnia. But also, you're not going to be able to get as much oxygen into the lungs because of that actual obstruction, and that's going to cause hypoxemia. Another thing that we have to think about with chronic bronchitis, and I want you to think naturally here, if you remember from our pneumonia video, we talked about how chronic bronchitis, or COPD, puts people at risk of developing infections, lung infections, especially because of the mucus plugging. If you guys remember, there were two bacteria that are commonly seen in patients who have COPD that can actually cause this increased risk of pneumonia. So there's going to be an increased risk of pneumonia. And again, this was because of two types of bacteria. One is called Haemophilus influenza, we're going to put H flu, and the other one is called Morphology catarrhalis. Okay? These are the ones that are going to increase the risk of that pneumonia. And again, when we talk about this, this could be usually your strep pneumonia. Or it could be a lobar. So here would be a, this right here could be a lobar pneumonia where it's actually forming what's called a consolidation. And then this one over here on the left side could be a bronchopneumonia where there's actually diffuse scattering, particularly at the bases of the lungs. So that's going to be an increased risk of pneumonia, okay, because that mucus is building up. And because of that mucus building up, it's going to lead to that H flu and that Morphology catarrhalis just basically feeding in that area, which can then again lead to an infection. So these are the big things that I want you guys to see, especially with chronic bronchitis, okay? So again, to recap it, hypertrophy, hyperplasia of the mucus glands and the goblet cells, that causes mucus buildup. Ciliary dysfunction because the smoking and the pollutants destroy the cilia and lead to either a decreased number in the cilia as well, shortening the cilia, and less motility, leads to mucus buildup. That mucus buildup can form plugs. The plugs can lead to air trapping, okay, which is a classic sign. Again, because of the mucus plugs, you can have less oxygen coming in, leading to hypoxemia, less CO2 being blown out, causing hypercapnia. And another complication that can develop because of chronic bronchitis is you increase the risk of developing pneumonia, especially with chronic bronchitis because of the mucus buildup. And particularly H flu and Morphology catarrhalis are the etiological bacteria responsible for that. Okay? So that's chronic bronchitis. We're going to talk about another complication that is extremely common, and it's a bad diagnostic sign in patients who have chronic bronchitis, and we'll get to that when we get to this part here. Okay, let's go to emphysema for a second, and then again, we'll talk about the complications that can develop from these two, the biggest one. With emphysema, again, I want you to remember that this is a structural issue, And then for chronic bronchitis, I want you to remember that this is a mucus issue. With emphysema, what happens is these situations here, the smoking, the pollutants, or another one that we'll talk about, alpha-1 antitrypsin deficiency, all lead to this condition. How? Let's go with the first two here, the smoking and the pollutants. So let's say here I have some pollutants, okay? Let's say that it's from the smoke, from cigarette smoke, or maybe it's from the silica, the dust. What it will generally do is we have certain types of cells in this area, right? And they're resident macrophages. These are called alveolar macrophages. And what they'll do is they'll undergo phagocytosis of this actual, these pollutants or particles. Now, when it undergoes phagocytosis of these particles, the next step is it's going to go ahead and start actually releasing particular cytokines. So now look, it'll undergo the phagocytosis of the particle. Once it's activated, it's going to start releasing a bunch of different cytokines. These cytokines are going to activate some particular nice little cute cells to this area, and these are called neutrophils. So there's going to be a lot of neutrophils. There'll also be some more macrophages that can come to the area, but one of the main culprits in this is going to be your neutrophils, okay? So these cytokines are going to activate these guys. Now, when these cytokines activate these guys, it's going to basically say, okay, there's a lot of inflammation in this area from this smoke or dust or silica or pollutants. What the neutrophil and the macrophage are going to start doing is they're going to start releasing particular proteases. So they're going to start releasing these specific enzymes. And the enzymes that they're going to release are going to be called proteases. So they'll release proteases, they can release other enzymes as well, but these are going to be the big ones. But the main protease that I want you to remember that it'll actually start releasing here is called elastase. Now you can already imagine what that does. Elastase means it breaks down elastin, which is a connective tissue, right? So because of that, you see this pink stuff here? This elastin has multiple functions, okay? So let's recap really quickly. What is elastin for? Like, it's important to understand sometimes in anatomy and physiology comes in handy when it comes to talking about pathophysiology, obviously, right? So one of the big things for elastin is it helps to increase the recoil of the lungs. What do I mean by that? You know, whenever we're inspiring, it requires respiratory muscles, the diaphragm, the intercostals. And so because of that, that's going to expend energy, but that's a whole part of the inspiration. It's an active process. Expiration normally should be a passive process. So whenever our lungs are actually reached their full capacity of inhalation, the elastic tissue is designed to draw the lungs back to their normal size. But if you lose that elastic recoil, then what's your lungs going to do? They're going to expand really easily, but they're not going to be able to recoil and push a lot of the air out. What does that cause? That air trapping, right? So that's one big thing here. It also keeps airways open at the same time. So think about this. If you're exhaling, right? Remember I told you when you exhale, your respiratory airways get a little bit smaller, right? If you had elastic tissue, it actually keeps those airways open. They have an opposite force. It's called the Bernoulli Principle. So the Bernoulli Principle says that in the airway, there's going to be low pressure because of high velocity airflow. So you need elastic tissue to pull in the opposite direction to keep that airway open. But if you lose the elastic tissue, you lose that opposing force. And so then what happens? The pressure inside of the actual airway is so low, the airway will collapse. And again, that contributes to the air trapping, and we'll talk about this here. But again, that's the significance here. So if you actually have a lot of this constant exposure from the smoke, the pollutants, these irritants, or you have alpha-1 antitrypsin deficiency, it's going to cause increased macrophage phagocytosis, increased inflammatory cytokines, increased number of macrophages but particularly neutrophils to come to the area and release a ton of proteases. The proteases, the specific one is elastase, but it does have collagenases. The elastase is going to do what? It's going to start breaking down this elastic tissue, this nice pink tissue here. And again, imagine what that's going to do. It's not good, I can tell you that, right? So you're going to lose your ability for your lungs to recoil. That's going to lead to an increase in compliance, but air trapping. And you're not going to be able to keep the airways open. So they're going to collapse, and that's going to again contribute to the air trapping. So let's talk about how that happens. Okay. Oh, but before we do that, one last thing here. I talked about these pollutants, right? How does alpha-1 antitrypsin deficiency come into this? I want to make sure I mention this. Let's draw the good old liver, my favorite organ. This guy here is so cool, and what he does is he releases a specific protein into the blood, right? And this protein is called alpha-1 antitrypsin. Alpha-1 antitrypsin is an antiprotease, okay? So because of that, its job is to inhibit the action of these elastases. So if you have your liver producing this at constant amounts, what it's going to do is it's going to try to be able to break down this actual elastase and prevent it from being able to cause this damage to the elastic tissue. Can you imagine that if you had an autosomal dominant disorder, so autosomal dominant disorder, and again, that means that you actually have two defective copies. And what happens is your liver isn't able to produce this alpha-1 antitrypsin, or if it does, it produces in a very little amount. What's going to happen? Your inhibition of the elastases is going to be overcome. And you're going to have a lot of elastases, and they're going to start producing damage. So you can see why alpha-1 antitrypsin deficiency can be a cause here for emphysema. Now, going back to that thing I was talking about with the Bernoulli Principle, let me put that down in this diagram. So this is the Bernoulli Principle. And what the Bernoulli Principle says is that when you get air coming out of the lungs, okay, air leaves in a high velocity, okay? So it's going to leave in a high velocity manner. So when air is leaving in a high velocity manner, what happens is the airway inside of there should be a low pressure. So because of that, high velocity means you're going to have low pressure in the airway. Think about this. If there's low pressure and there's higher pressure out here, what's going to happen? The airway would collapse. But guess what? We got that beautiful elastic fibers. And what the elastic fibers do is they create an outward force. And this outward force is going to help to be able to keep the actual airways open, even despite the fact that air is moving at a high velocity and causing a low pressure in the airways. Imagine for a second though, you lose this elastic tissue. Then what? This pressure, it's going to be low. Are you going to be able to resist the collapsing pressure? No. So because of that, what would be the result? Think about it. So imagine this for a second. Imagine you lose this elastic ability to keep the actual airway open because, again, the low pressure according to Bernoulli's principle. What will happen is whenever you try to exhale, you're not going to have that actual elastic fibers to keep it patent. So now, when you exhale, the airways are going to collapse. And because of that, what's going to happen to that air? It's just going to sit here in this actual acinus. And then over time, as that air starts to collect, guess what happens? Oh man, you start losing the surface area. And it starts getting really, really expanded. And because of that, not just because of the loss of the elastic tissue in the small airways, but you also lose a lot of the elastic tissue in the alveoli area. So it starts actually breaking down the alveolar septa. And because of that, you just get a small surface area. It destroys the surface area. Okay? So that's what I really want you to remember. Because of emphysema, you lose the elastic tissue here in the actual small airways. Because of that, whenever you exhale, they aren't able to keep the airway open, it collapses. When it collapses, air is trapped and it's not able to be left from the lungs. Because of that, over time, that air starts actually causing kind of dilation and expansion of the actual small airways, or the acinus. Another thing is the elastases start breaking down the alveolar tissue which form the septa. And so now instead of having little alveoli to increase the surface area, you just have one big ballooned out area of an sinus. And that's a problem, especially depending upon what kind it is. And we'll talk about those because they can cause pneumothorax. All right? All right, so I just wanted to make sure that I mentioned that. Now, the next thing that can happen here is think about it. If that airway collapses, what's going to happen? Are you going to be able to blow CO2 out? No. So because of that, think about it. The CO2 that you're trying to exhale is going to start building up because it's going to be so narrow. In the same way, think about oxygen. When that oxygen is going to be able to come in, because again, here's what I want you to remember. There's the big thing with the oxygen is with chronic bronchitis, that mucus is still going to be there. During inhalation, you're able to bring air in with emphysema, but it's just not as much, okay? Hypoxemia and hypercapnia are way more common in chronic bronchitis. Hypoxemia and hypercapnia for emphysema is usually a later event, okay? A lot of the problems with the COPD is with expiration because of, again, when we expire, those airways get a little bit more narrow, especially if there's mucus blocking it or if you lose the elastic tissue. So that should make sense. But again, there is going to be a little bit of oxygen, not as much getting into the airway. So what's that going to lead to? If you think about it, that's going to lead to, again, hypoxemia, and as well as hypercapnia. But again, what I want you to realize is that it's very mild, okay? And this is usually going to develop later stages. So after someone's had chronic emphysema for a long period of time, they're going to develop hypoxemia and hypercapnia to the point where it actually is severe and it can lead to a very, very dangerous complication, right side heart failure, and we'll talk about that. Okay? So again, we understand the collapsing of the airways. We understand one of the big complications that can develop within the later stages of emphysema, more common in chronic bronchitis. The next thing I want to make sure that we mention is the morphology. So remember I told you that with that actual, that sinus, over time it becomes kind of dilated and because of the air trapping. And on top of that, the elastic tissue is being destroyed and it's losing the alveolar septa. And because of that, you just develop these big balloons in the actual lungs. There's 3 types of emphysema that we generally see. So again, this one is called centriacinar emphysema. Okay? Now, here's what I want you to remember. Again, going off of that little diagram I had here, this one here. Remember, as the airway gets narrow, right? And over time, as the elastic tissue starts actually becoming destroyed, it leads to these big dilated pockets of air with decreased surface area. They can occur in different parts of the airways. If these dilated pockets of air form in the proximal airways, it's called centriacinar emphysema. If these pockets of airways, these dilated pockets of airways develop in the distal airways, okay, like more of the distal airways, that can form another type, and that is called panacinar emphysema. Panacinar emphysema. And the one that's really, really bad, and we really got to watch out for, is when it affects the distal alveoli. And the distal alveoli usually are forming near the actual pleural tissue. Okay, so near the actual visceral and parietal pleural area. So because of that, this is the one that you got to be careful of because it can actually form little blebs that can rupture and form spontaneous pneumothorax. Okay, so this one has 2 names. I'm going to write this simple one. It's called distal acinar emphysema, but they also call it paraceptal emphysema. This is the one that I want you to remember because specifically this can form, one of the complications that can develop from this one is you can develop a pneumothorax, usually a secondary spontaneous pneumothorax, and that can lead to atelectasis, compression atelectasis, where the lung can collapse. Now I'm going to highlight again, just to be specific, where these actual these little dilated airways or expanded airways would occur. For distal, again, remember, near the pleura, okay? So this green here that I'm highlighting, this is where it will generally occur. So you'll form these different types of little blebs, little dilated airways near the distal alveoli. That's usually in the periphery of the lungs, okay? Panacinar usually affects the lower lobes of the lungs. Centriacinar, usually, since it affects the proximal airways, affects the upper lobes of the lungs. Okay, so it's not too hard, right? Again, centriacinar, proximal airways, upper part of the lungs. Panacinar, distal airways. Again, that should be the lower part of the lungs. And then distal acinar is it affects near the actual alveoli, or they also call it paraceptal emphysema. And again, it affects the distal alveoli, and that's going to be usually near the pleura. And again, these can actually form little blebs that can rupture into the actual pleural space. And that air in the pleural space is called a pneumothorax. We call it a spontaneous pneumothorax, but it's secondary because they have an underlying lung disease. Okay? All right, so that's the big things that I wanted to make sure that we mention here with the emphysema. Now, remember I told you that there was a big complication that can develop with emphysema and chronic bronchitis. And it was related to this hypoxemia and this hypercapnia. And again, I can't stress this enough. Hypoxemia and hypercapnia are way more common in chronic bronchitis. It can happen in emphysema, but it is usually in the late stages, okay? How does this work? Well, if you guys remember a little bit about your physiology, what happens is, over time, you have this hypoxemia. If you remember, kind of a small little diagram here, let's say here we have an alveoli. And then here we have a blood vessel. If you guys remember, we said that whenever there is low ventilation, low V, right? Base it off that VQ ratio, which is equal to 0.8, okay? And again, this was what we learned in physiology, okay? We say that a VQ is equal to 0.8. If you decrease the ventilation to the alveoli, what do you need to do to the denominator to actually make it to at least equal 0.8? Well, if you decrease the top number, it's going to make the overall number smaller. So we have to make the perfusion also smaller. So as a result, we have to decrease the perfusion so that we can bring the overall number back up to 0.8. So because of that, whenever you have low ventilation to a specific point of the airway, it is going to decrease the perfusion. And you can remember because they called that hypoxemic vasoconstriction. It's a normal auto-regulatory mechanism of the lungs. So with hypoxemia, it's going to result, with this situation of low ventilation, it's going to lead to hypoxemic vasoconstriction. Now that's fine if it's only just a small part of the airway, but imagine if this is affecting multiple parts of the actual lung. So imagine that there's actually multiple of these guys, multiple of these alveoli within the lungs that are having so much vasoconstriction. Eventually, these pulmonary vessels are going to develop a really, really high pressure, okay? So because of that, imagine it like this. Imagine this kind of diagram. Imagine here there's one arteriole, and this arteriole branches out into multiple different little terminal arterioles. And these guys are going to the alveoli. I'll draw a little alveoli here, little alveoli there. Imagine this one had low ventilation. What do? You constrict it, right? So now this area here, as a result, will constrict if there was low ventilation. Send it to the other areas. But what if this alveoli is also having low ventilation? Then I'm going to constrict that one too. What if this alveoli is also having low ventilation? I'm going to constrict that one. Where's this blood going to go? It's just going to go backwards and build up. What's that going to do to the pressure in this area? It's going to increase it, and it's going to cause what's called pulmonary hypertension. because you're having so much widespread vasoconstriction that this is causing the blood pressure to rise so high in the pulmonary arteries. So this hypoxemic vasoconstriction over time can lead to pulmonary hypertension. I'll put HTN. Now think about it like this. If the pressure in the pulmonary arteries are high, then the ventricle, the right ventricle, is going to have to increase its workload. It's going to have to pump and pump and pump against high pressure so that it can push the same the same stroke volume out. Because of that, it's going to put so much workload on the right side of the heart that eventually there can lead to what's called right ventricular hypertrophy, but then unfortunately, over time, failure. And this is what we refer to as cor pulmonale. It's a complication that can develop because of chronic obstructive pulmonary diseases. And how would you know that if somebody has right ventricular failure or right side heart failure? Remember, the fluid backs up into the superior and inferior vena cava. So what will they have? An increased jugular venous pressure. They'll have hepatomegaly, splenomegaly maybe. They'll have peripheral edema. All of these things are going to be common signs of someone having right ventricular heart failure. So again, that is something that we want to take into consideration as a very serious complication of chronic obstructive pulmonary disorders. Again, you will see this more specifically with chronic bronchitis or the later stages of emphysema. Okay? And again, ruling out right ventricular heart failure, obviously you have to check their BNP levels. It's called the brain natriuretic peptide. It's made by the ventricles. You could do an echo to see if there's a decreased ejection fraction. And if you really want to, you can check what's called a Swan's-Gans catheter. It's a right ventricular catheterization, and you check the pulmonary capillary wedge pressure, and you look to see if it's greater than 18 millimeters of mercury. Those are usually ways that we can see if a person has right-sided heart failure. Okay? But again, the gold standard would be the Swan's-Gans catheter. All right? So that's what we would have to know out of all of these for a chronic bronchitis and for emphysema pathophysiology.